Hello, everyone. My name is Jose Francisco, Project Manager at the IAS-USA. Today's webinar will be going over the implementation and clinical management of injectable antiretrovirals for HIV treatment. I'd like to welcome today's moderator, Dr. Michael Saag, Professor of Medicine at the University of Alabama at Birmingham. Welcome, Dr. Saag.
Thank you, Jose. Welcome, everybody. We've got a pretty data-packed hour to hour and 15 minutes to share with you. I'm very pleased to moderate the webinar with Dr. Marina Klein, who is a professor of medicine at McGill University in Montreal. And what we're going to do today is cover the waterfront of how injectables are going to be implemented in our practice as they are rolled out. And we're going to be speaking with Dr. Klein, who in Canada, these drugs have been approved. This drug in particular has been approved for almost a year, but the rollout has been a little bit slow. And Dr. Klein can talk about that, mostly regarding provinces and their ability to work out an agreement with the manufacturer. But we're all going to be seeing them in Canada and United States and around the world. So this is a sort of a background review for all of us. Next slide, please. So this is a CME accredited event. This is sponsored by the International Antiviral Society USA, for which I am a board member of the organization. And this is designed for 1.25 AMA PRA Category 1 credits. And we'll talk about claiming the credit at the end, but if you stick around for the whole hour and 15 minutes or so, you will get that. So these AMA credits also can be used for ABIM maintenance certification points, but also through collaborations, we provide 1.25 nursing contact hours, 1.25 of pharmacotherapy credit, and 1.25 of pharmacy contact hours, which equivalent of 0.125 CEUs for the pharmacists. The grant support for the webinar is listed by the folks below, the companies below. This is part of an ongoing webinar series that the IAS-USA receives funding from the organizations as an unrestricted educational grant. The decision about what topics to cover, who the presenters are, is solely at the discretion of the IAS-USA as the sponsor of the CME activity. So we're grateful, especially to our platinum sponsors, but also to obviously our silver and bronze supporters. Next. So we're going to have poll questions throughout the event today, and that'll pop up on your screen. You obviously just select, click, and then when the polling is done, the results will be shown to us by Jose and the team at IAS-USA. And then if you have questions, which I'm sure you will, as we go through, my job as moderator is to monitor the Q&A button down below. So at the bottom of your screen, as everyone's used to Zoom by now, there's a little Q&A button. Just type in your question, send it in. And Dr. Klein has agreed for me to kind of interrupt and pepper her with questions. I'll have some of my own, and I'll have some of my own commentary as we go along in the presentation. So feel free to submit them. I'll read them off if you'd like. Just include your name, and I will read that off as a question from Dr. So-and-so from location. Just let me know the location, and that way we'll be inclusive of what we're going to do. Normally, we will have waited to the end for the Q&A, but we felt like with this webinar and things being so new, we're going to keep it more informal and do the Q&A as we go along. So therefore, there won't necessarily be an end of the webinar Q&A like we've done in the past. Next slide. So here's a test of the polling system. So how many of your patients have received an injectable ARV agent? And this can include those of you who have been participating in clinical trials. That would that would be okay. So let's go ahead and vote now. I usually include music here. If it were music for today, I'd probably include music from Dear Evan Hansen, because they just announced and put up the trailer on YouTube for a movie that'll be released. Okay, so the majority have not used it yet. And some folks have used it more than 30 patients. Those are folks, I'm sure, that are clinical research sites. So let's close the poll. Next slide. And at this point, we're going to stop sharing our screen. Dr. Klein is going to share her screen, and she will take us through her presentation. And what I'm going to do is I'm going to shut off my video, which will make me disappear. And then as I have a question, I'll pop back in. So Dr. Klein, take it away.
Yes, thank you. Thanks so much, Dr. Saag. This is really a great pleasure and a privilege to be able to do this presentation with you today. And I'm really pleased that we'll do this in an interactive way. I think with the dawn of these new injectable therapies, it's really a new era or a paradigm shift in treatment for HIV, one which we've sort of been, thinking about, dreaming about for many, many years. And it's finally really here on the horizon. And as always, with the first iteration of a new change, there are going to be a lot of considerations and a lot of learning that still needs to take place about how to use these therapies, and most importantly, in whom to use these therapies. And I think that's evidenced by the tremendous registration for this session. I was quite surprised by the numbers that pre-registered. I heard it's a record, and the really excellent questions that have come in the talk period. So hopefully Dr. Saag is going to be able to address many of those as we go through, and that we'll have time to interject them along the way. I haven't presented a lot of material. So these are the learning objectives. And as the hope that on completing this webinar, learners will be able to describe potential benefits of injectable antiretroviral drugs for treatment of HIV infection, describe potential challenges in implementing treatment with these drugs, and propose ways to address these challenges and incorporate ultimately injectables into clinical practice. And as I mentioned, really this is, we're at the start of this adventure, I think. As Mike mentioned, Canada was the first country in the world to approve their use back in March 2020, which was also a watershed moment for the world for other reasons. And because of that, this year has been probably slower in terms of how we can implement them. And when I agreed to do this talk quite a long time ago, I thought, well, we would have had a lot of experience doing so by now, but we're really getting off the ground, maybe a little ahead of the US, but not that much. And so this is why I think it's a good moment to be discussing what are the considerations that we need to think about when we want to implement them in practice. So the point of today's discussion isn't to provide an exhaustive overview of all the data, but really to highlight some of the key points that can inform a wider discussion that we're going to have today. And certainly this is really the beginning, and I'm happy to be able to share what I can with you. So we're going to start with some pre-test questions. So the poll is up. This question is the ideal patient for injectable antiretroviral treatment is someone with a long history of non-adherence, a young active man who travels frequently, someone who's reluctant to disclose their HIV status, or a woman who's contemplating pregnancy. So please vote. Just to say, the answers to these questions will be addressed throughout the course of the presentation and discussion today, and then we will come back to them at the end with the results. And so this is the results. So the first answer to this question is interesting. Someone with a long history of non-adherence, 39%. Second was a young active man who travels frequently. And that was the third. And the second choice was someone who's reluctant to disclose their HIV treatment. Okay. And we will move to the next pre-test question. Which statement is true about injectable antiretroviral treatment? It can be given without an oral lead-in when HIV is undetectable. It can be given every 2 months, every 3 months, and in patients receiving TB therapy with rifabutin. Please vote.
I've learned to swim on the break.
Oh, Mike is putting music on for us.
Before I make the mistake. Before I.
Okay, so, and here are the results. The first answer was every 2 months at 56%, and then the other three are relatively similarly answered. So we will come back to this at the end of the presentation. So why are we even thinking about injectables? I mean, there are so many really excellent HIV treatments available to us now as single tablet regimens with high efficacy, low side effect profile, generally don't have difficulties with drug-drug interactions. So do we really need injectable treatments? Well, HIV clearly remains a long-term chronic condition that requires lifelong daily oral treatment. And we're not going to talk much about, or at all about, biomedical prevention today, but we are also envisioning injectables in the setting of biomedical prep. And that needs to be frequent oral medications in otherwise healthy people who might not wish to take pills. And so despite the success of daily oral antiretroviral therapy, there are many challenges that still exist. And I think we're increasingly recognize the importance of stigma and frequently internalized stigma in people living with HIV and how that can play into their relationship with treatment, with healthcare, and with medications in their daily lives. And as people age, the pill burden is also increasing. And these factors can interact with each other to have impacts on adherence, which if over time adherence is difficult, treatment failure can arise. I select this as an example, and I think we hear many different experiences from our patients, but I think it's important to think about the people for whom we are discussing these therapies with, as they often experience life that's very different from what we realize. So this is a quote: "I often hear my friends speak negatively about people being HIV positive. They always have degrading or negative remarks to make. What I dislike most is when they call people names," which I won't read out, but you can read them. "Whenever I go out with them or have them come over to visit, I don't take my medications. I could never let them know I'm positive." And this came from an HIV positive African-American woman living in Baltimore. And in fact, adherence in real life is probably underestimated. I thought this was an interesting study that was recently published, and it looked at Medicare claims data. So this is quite a crude measure of adherence, but I think is quite conservative in the sense that it defined adherence as less than 5 days late to refill their medications from Medicare claims data in the US. And what you could see is initially, after the first month of treatment, very high rates of adherence. And this compared single tablet regimens to multi-tablet regimens. And the purpose of this study was actually to look at if there was a benefit of the single tablet regimens. But what you note is quite early on, and then over time, there's a gradual decline in the levels of people who were fully adherent to their medications that met this criteria of less than 5 days late, such that I think we underestimate this importance, and it's really a testament to how forgiving many of the current regimens we are using are in terms of that we just don't see this level of treatment failure. So there's clearly an unmet need for a big segment of the population. So what do we have available to us? Well, we have long-acting injectable ART, or only this combination, cabotegravir and rilpivirine. Cabotegravir is an HIV-1 integrase inhibitor. It's available in 2 formulations: as an oral tablet, 30 milligrams, which has an extended half-life of about 40 hours. And its intramuscular long-acting form, which comes in 200 milligrams per mil and has a half-life of 40 days. And this is combined with rilpivirine, a medication that we've known for some time, an HIV-1 non-nucleoside reverse transcriptase inhibitor, and is part of a single tablet regimen currently with tenofovir alafenamide and FTC. It's an oral 25 milligram tablet with a long half-life, which is the reason that these two drugs actually were developed for intramuscular injection is their properties. And it's available as a long-acting injection in 300 milligram per mil, and its half-life is 90 days. So I'm gonna briefly review some key data slides just to show where the indication for these medications has been supported. And I'm not going to go into tremendous detail because I'd rather have some time for questions and answers. So these are the pivotal trials that were done, Atlas and Flare, which tested in Atlas adults who were already on stable antiretroviral therapy, either their first or second line regimens, who had undetectable HIV RNA for at least 6 months and no history of prior virologic failure. And they were randomized to receive either cabotegravir or rilpivirine or continue on their baseline antiretrovirals. And as you'll see, the theme of the way these drugs are administered is that there's a 4-week lead-in period with oral cabotegravir or rilpivirine, followed by a switch over to the injectable formula. And this had its primary endpoint at 48 weeks, but the people who were enrolled in this study were eligible to actually go on to an extension, which I'll talk about in a moment.
So, Marina, before you go forward, one of the questions that was submitted earlier was, is it necessary now to have that 4-week lead-in? In other words, as this is now available for practice, is that something we're still going to do?
Yeah, I think it's an excellent question. Yes, and the rationale principally for that is, here these are stable people on ART, so you're not so worried that if you switch them over to another medication, you're not going to keep the virologic control. But what we're worried about is these long half-lives of the injectables, as I'm going to show you in a moment with their long tails, is that if someone were to have an intolerance to the medication, you can't get it out of the system. And so you really need to have that period of time where you're exposed and could withdraw the medication safely. So it's more of a safety issue rather than a concern about efficacy. Right, and so for the other study, Flare, this was ART naive patients and who only prerequisite is that they didn't have chronic hepatitis B infection or any evidence of resistance except possibly the transmitted K103N, which was permitted. They were initiated on triple therapy with dolutegravir, abacavir, 3-TC for that period of time to ensure that they could be suppressed of 20 weeks and then randomized to receive either the cabotegravir or rilpivirine arm or to go on to continue with their 3-drug regimen. And all these studies, I'm just going to show you, have the same sort of layout in terms of how we look at the data. Primary endpoint virologic success, we can see that they're very similar. This is continued baseline ART in orange in Atlas compared to the experimental arm with the injectables. Notice that non-virologic response was very few. And some of the difference in these two arms was reflected by not having virologic data in window. This summary is basically that for both the primary and secondary endpoint, that is virologic failure, there was the injectable was non-inferior to continuing on baseline antiretroviral therapy. And similarly, non-inferior to the comparison arm for achieving an undetectable viral load below 50 times. Flare, so that second study where the comparator arm is abacavir, 3-TC, and dolutegravir. Again, very comparable between the two arms and non-inferior. This is 96-week data now, so this was presented at CROI in 2020. And so for the two outcomes. So demonstrating efficacy in both cases. Finally, this is the extension phase that I think has been quite interesting because it asks the question, wouldn't it be ideal if we could extend the interval between injections from 1 month to 2 months, because that would mean half as many injections per year. So you're talking about interacting with the health system only 6 times per year, possibly, as opposed to 12. And so this took people who are either in the original Atlas study who were on the cabotegravir arm or on the standard of care arm and also patients who were neither in those studies. So it was sort of a mix of people. If they were not already on the injectables, they had the lead-in, and then they were randomized to receive either 4 weeks or 8 weeks, that interval. So it's changed the interval, and then had an option to kind of continue on. So there's a long-term follow-up phase of this data. We've just seen the 96-week virologic outcomes for this trial. And again, remembering that people coming into this trial, many of them had already been well controlled on the cabotegravir ripivirine, maintain that control in the long-term follow-up period. And there was a non-inferior with respect to comparing 4 weeks versus 8 weeks for both of the outcomes. So I don't know if there's any questions that relate to that data, Mike, that before I move on to some of the.
Yeah, there's a bunch of them. I'll try to, maybe we'll do short questions, short answers to get through as many. One is that Lut van Dam is saying that ViiV is assessing whether the oral run-in could be optional, and that's being done. Another question from Gary Spinner. After you finish the 28-day oral lead-in in practice, is it necessary to, are there any labs that you would want to get before you move forward with the injection?
Well, that's a good question, actually. And it's not, so I think it sort of depends where you're going to be using these. And I think if you're in people who are stable, virologically suppressed, they've been on the oral lead-in, I think you could transition directly on without doing major labs. It sort of depends where they're coming from. I think we don't expect high toxicity with these drugs, right? They're quite
right.
So I think it has a little bit more to do with the underlying comorbidities of the patient, whether you could expect it could have some toxicity, or whether they're relatively naive to treatment, as opposed to people who had a longstanding history, but not necessary. Yeah.
Right. What about Brian Montague wants to know about people that have high BMIs, and is there any kind of recommendation? Because those very high was sort of excluded from the trial.
Yeah, I'm going to come back to that question in a little bit because I think.
Okay. And then Emma Kaplan-Lewis, can you discuss the FLAIR OLI trial where participants were given the choice of oral lead-in? Long-acting antipsychotics or birth controls aren't given an oral lead-in first. So do you think we'll ultimately get rid of that requirement?
You know, personally, I think right now the indication requires it. I think there's good rationale why it's probably possible to get rid of it. I mean, my view is these are, very safe drugs. I'm not going to go through all the, the side effect profile in detail, but there've been very few major adverse events with these drugs. And if you don't have an allergy to a component of them, and then you're very unlikely to have a treatment limiting adverse event that would require it being stopped. So I think under supervision, there's no reason why you couldn't probably for many people do away with the lead-in ultimately. Yeah. I think
Brandon Twardy from Case Western wants to know, would you recommend waiting a full 6 months before starting injectables to see how adherence is, or do you would just go ahead and start sooner than that?
Yeah, that's an excellent question. This is one where it gets a little tricky because I think the product label differs in the two countries. And the feeling by most of the clinicians that we've had in these discussions is that it's probably not required to have that long a waiting period of time. We don't do that for most other interventions with HIV. We're being a little bit, I would say, upfront, a bit paternalistic about how we approach this because it's all new and we haven't had the experience with it. But we'll talk, I think it's a good question to kind of come back to maybe in a discussion about how do we select the right person. So if there's someone who you're already, a little more concerned about adherence issues and you've gone to choose this regimen for them, then I think you may have a closer monitoring period to observe how they do in terms of interacting with the health system, if they're new to antiretrovirals, for example. But if you have someone who's been long-term stable ART, I don't see at least the physiologic rationale for waiting that long before doing this switch.
Yeah, that makes sense. We'll finish this part up with Shane Christian's question, which is basic, which we haven't said yet, but asking about how the cabotegravir and rilpivirine are administered as one single injection or two out of one vial.
I'll come to that. I'll come and show you that in a few slides, I think.
Okay.
Great. Okay. So I'm just going to move on to some of the basic issues, because there are some side effects associated with these drugs. So they're not completely benign, of course, every intervention we do. The major one is injection site reactions. And I think this is the thing that people may be most turned off by if you're presenting them to patients or not, depending on their experience with having had intramuscular injections before. And indeed, they are relatively common, but relatively mild. So overall, there's most people will report some injection site reaction. What's interesting is that seems to be habituated over time. And so obviously, if you have a Q8-week interval, you're going to have fewer of these because they're spaced out. However, as I'll show you later in terms of the dosing, the level of injection site reactions is somewhat higher with the 8-week dosing, because the dose is bigger, and so the volume that you're injecting intramuscularly is bigger. So you would expect to have a little bit more, but even then it seems to wane quite a lot over time. And most of these are pain and nodules that can form, pain at the sites. Nodules are rare, discomfort is obvious, and none of them are grade 3 or above, really. And so I think this is a point that's been presented, it's been discussed, this idea of what was the patient-reported preference in terms of receiving these drugs. And with the caveat that these are people who entered into the trials who are very keen to get these drugs to start with. I think we have to realize that the first people who were exposed are those people who really wanted to have injectables. But that is likely also be the first people who are going to take these in clinical practice. I mean, they're going to self-select to some extent because they want to try injectables. So, and there's really quite a lot of preference for this. So in Atlas, remembering that we're having people on stable CART and they transition to the new long-actings, or in FLAIR, where these are naive patients who do a period of at least 20 weeks of an oral agent before switching over, there's overwhelming preference to stay compared to the oral agent to the long-acting. So, and I'll say that, we've had unfortunately, my only major experience with this has been in the context of the trials and not in clinical practice yet, because of, as Mike alluded to, we've had, it's been slow to be reimbursed by our provincial health payers. This has been a noticeable thing, that people really feel somehow liberated, their quality of life is improved. It's more than you would almost expect in some cases, which was quite nice to see. And my colleagues in Ontario, who actually are a little ahead of us in terms of the numbers of people that they can get onto this treatment, have experienced the same thing. Okay, so there are some considerations, and this gets to the dosing interval. It gets to thinking about what happens in terms of managing people if they don't show up for an injection on time. And it gets to 4 versus 8 weeks. So the pharmacokinetic tail is what we here talked about. And just to orient you on this slide, you have the IC90 for cabotegravir on this side, and for rilpivirine on this side. Recognizes this is a logarithmic scale. And so of course the 0 to 1 month, as you'll see, we're giving a higher dose initially, you get a very high levels, and there's some drop off. As of 1 month, you're getting the standard dose, and in the green are the Latte 2 study 4-week, and in 8-week is in blue. And so what you're gonna see is that in the blue lines, occasionally people falling, well, in one case, someone falling below the IC90 by 3 months, but by and large, you've got good levels above the IC90 out past 3 months, which is what led to the move towards evaluating this. Similarly for rilpivirine. So there are some, as always, different metabolizers, and some people might be quite just at the limit. So this is the reason why going more than 3 months is likely a non-starter, and why we have to be a little concerned about really keeping to that 2-month injection time for people on the every 2-month regimen, so that if they're late, then we could have some issues, and that's why we have to. This tail also has implications for women who might be considering pregnancy, because this tail persists for quite a long time. So in the previous slide, I showed you, we're concerned about viral suppression with the IC90. Here, we're concerned about ongoing drug exposure for many, many, many months. So while the half-life are extraordinarily long, and this is impacted by BMI. So this is one of the areas where you can see about the pharmacokinetics related to BMI. So in low wage people, this drops off more quickly, but in people with a high BMI over 29 in this slide, this section here, you can see that this could take out to 52 weeks. You could have, measurable detectable levels of cabotegravir in the blood. So this is the recommendation for, until we don't have safety data in pregnancy for this drug. We don't recommend women who are contemplating getting pregnant to choose this option at this time. Dolutegravir, we've been reassured recently by the ongoing monitoring with dolutegravir from the Botswana cohort. And so if a woman does become pregnant, and it did happen in our trials, the chance that this drug exposure can have meaningful impact for the fetus is very, very low. But I think this enters into the conversation when we talk about these treatments. So but the other major consequence of the tail is the one that we're most kind of talking about and discussing, and I won't have time to go into this in great detail, but I think the concern is that for those people who fall below that level, could we see an increased risk of resistance emerging in treatment failures? And this is the summary of the recent data that combines the Atlas 2M study, 8-week and 4-week arms, and the numbers of confirmed virologic failures are listed here. So there's a total now of 11. There was one additional confirmed virologic failure in the between 48 and 96 weeks. And so we have now a total of 11 from these studies combined. And what's notable is that in the 8-week arm, and 7 of the 9, and in one of the 2 from the 4-week arm, there's failure with resistance mutations in the rilpivirine RAMs that are observed, and also in the integrase inhibitor. What's important is just look at how rare this event is, but this event does occur, and this is one of the things that I think have made people reticent sometimes to think about in whom should we be giving these treatments. These are probably not treatments for people who are unlikely to be able to observe the quite strict interval between injections, or who are going to have to come on and off and on again because they have a chaotic life or are traveling a lot. There are some, so it's, as we've said, this is effective and safe. Virologic failure is uncommon, but with failure, these mutations do occur. And this one signature mutation, the 74LI, has been found to be present at baseline. And I'm going to show you in another slide, I think this one. These are some of the factors that were shown to be associated with confirmed virologic failure in a multivariate analysis that was presented at Glasgow conference in 2020. And some of these were present at baseline, so they could potentially be used to predict who could be at increased risk. Just want to say, the numbers of failures are very small, and they were quite small in this analysis. So our confidence around these estimates is not great. There's huge confidence intervals, but the factors that come out were the presence of baseline resistance mutations to rilpivirine, and that's the one I did mention, the 74 VI, the baseline HIV-1 subtype. So that mutation is actually quite associated with this HIV subtype A6A1, which is found principally in Russia, and most of the failures occurred in that subtype. And then this comes back to the question that was raised earlier. BMI seems to come out as an independent predictor of failure. And that's, so for every, increase in BMI by 13%, you have a, increase by kilogram and unit of BMI, you have a 13% increase in risk of failure. And so and reason for that is it may have to do with how this drug is absorbed, how it's distributed, and if these are same people who, remember I mentioned, who have difficulties with adherence in terms of their visits, these could be people who could be potentially at risk because they're going to have this longer tail.
So let me interrupt real quick. There's some really important points here, one of which it seems very prudent to get baseline resistance assessments, and we don't usually get integrase inhibitor resistance information prior to starting an integrase inhibitor in practice because it seems to work so well, even without screening in general. But it seems like we ought to be doing that if we're going to be going to this. And then it raises the question, technically, how do you go back in retrospect if you didn't get it at baseline, true baseline, you went on an oral regimen first? We're going to have to maybe be doing DNA assessments of resistance and trying to see if we can tease out some of that baseline information.
Yeah, so I think this is a matter of considerable discussion and debate. I think these were largely from proviral DNA samples, or they had a sample based at baseline stored. I think that the issue is, though, remember how these are quite rare, right? And many of them were also associated with this one particular subtype, which we don't actually see circulating in North America. And I think to recommend in people who are ART naive, given the background level of integrase inhibitor resistance, it has transmitted resistance being so low, I'm not sure we're at this point where you should have to have a pre-genotype done with proviral. What would we make of that if we see that? Because that patient would be present in a large number of people who didn't fail too. So
yeah, it's something to keep our eye on as this rolls out. And you're right, it may not be required, especially if a lot of this is a Russian variant and isn't directly applicable to those of us in places outside of Russia. Good point. Sorry to interrupt. Yep.
In this analysis anyway, and I think we need many more updates of this analysis, because just remember how few events there are. So whether we can detect real predictors is difficult. The 8-week regimen was not significant, but I think, again, this might be, again, we are thinking of, do we choose 8-week regimens for people who may be, less likely to have issues because they had prior drug treatment failures and might harbor some of these resistant mutations. That's the other consideration I think that might come in to the discussion. Okay, so I'll just quickly do some practical slides. This comes from the product monograph, the Canadian product monograph. And just to show you how it's given, because someone had asked this question about the injections. So the oral lead-in currently, 1 month, oral cabotegravir at 30 milligrams tablet once daily, and a rilpivirine tablet once daily. And then go on at month 2 to the initial injection, which is sort of like a loading injection, 3 milliliters. Yes, it's one injection in one buttock, and the rilpivirine, another injection in the other buttock. And then from month 3 on, so that means another month later, you go on to the maintenance dose, which is 2 milliliters or 400 milligrams of the cabotegravir and 600 milligrams of the rilpivirine monthly. The final oral doses should be taken on the day that the first injection is given. And the month is at least 28 days. For the 2-month dosing schedule, and as I understand, this is not yet approved indication in the United States, but it is in Canada as of about a month ago. It's a slight variation on the theme. Same oral lead-in, same idea with a loading initial injection, but that loading initial injection is given at month 2 and month 3, and then as of month 5 and every 2 months thereafter, you go on to continuing. So there's actually, it's not immediately to 2 months. You have to have a series of 2 monthly injections to start. Notice that the higher dose is given, which is like that loading dose that's given for the 1 month, but this dose is given at every injection. So a bigger volume, 3 milliliters. So it's quite a large intramuscular injection, but as I mentioned, generally very well tolerated. And then what if you're someone who's stable and on the monthly schedule and you want to switch to the every 2 month schedule? This is the recommended approach. So 1 month after the last monthly dose, and then you move to every 2 months thereafter, you go to the higher dose. I'm not going to go over the details of this, but just to say that there is and there will be release of these medications, recommendations for what to do when you have to bridge orally. So that is, if, for example, there's a late dose or a planned missed dose, say someone has to go travel and it's known that's going to happen, or they have to have some event that they can't be at for their injection, you can plan ahead of time. And it's actually recommended that when you do the initial prescription, you actually have a prescription for the oral bridging, such that if there's an unplanned injection that's missed, that they can immediately do the bridging and be instructed how to do that without having to, go to the pharmacy and hope that it's in stock, etc. So the interval, there's like a window period of 7 days that's given around these injections. And so if it's just under 7 days, then you just continue on. If it's planned and it's greater than a month plus 7 days, then you plan to do the oral switch over. And it should be approximately 1 month after the last injection done. And you try to resume the injections on the same day you would have had them once they complete the oral bridging period. If it's unplanned, then you need to do an assessment, really, of is this unplanned because it was just an interval life event that happened, or is this because the person is really not, is less organized or chaotic or can't maintain the injections, and is it appropriate for them to continue on or not? So these are the sorts of things that need to be discussed and thought about, and whether or not you need to do RNA testing for viral load at that time, just to ensure that they're actually aren't at risk of developing virologic failure. Okay. So there might be other questions that will come up around how to follow people, but I think we can have that maybe more in an open discussion. There are some people for whom we should not be giving these drugs to. Obviously, if you have a hypersensitivity to either components of this drug, and that was the rationale for the lead-in, I think, as we've discussed already, that may start to move away as an issue. Co-administration with strong inducers of UGT1A1 or UGT1A9, which include anticonvulsants, antimycobacterials, including rifabutin, which we use frequently, systemic dexamethasone, more than a single dose. Interesting, because in the era of COVID, I think we have to think about that. But St. John's wort, which is always on the contraindicated list. Known or suspected resistance to either of the agents. So this is, again, where, whether or not there's a role in someone who you might consider these for in doing a resistance testing, if you have a history of one virologic failure in the past with an NRTI, for example. And chronic hepatitis B infection, and the reason for that is these obviously do not have any activity against hepatitis B, and these people with chronic hepatitis B should be on a tenofovir or tenofovir alafenamide FTC, 3TC based regimen to co-treat. Okay, so I think we're going to move now really to spend the last part of this discussion about what are some of the potential challenges of implementing these injectables in practice. And I think the main one that seems to come out, and I think we're all looking.
Sorry to interrupt. Maybe we should, there's a couple questions on the last section. I think we can just quickly go through them, one of which is there's a couple practical things. And again, it goes back to increased BMI, of a need for a longer needle. And how do we get that?
Oh, yeah. I think that's the case. In fact, it was supplied with in the studies, but so we can talk about the practicalities of doing the actual injections, because one of the things that's being proposed, at least here, and it's probably largely going to be how it's going to happen, is that it's going to be taking place outside of the clinics at injection sites, at the places that have been used to doing administering biologics, for example. It'll be coordinated in that way, and that they will have all the materials necessary.
Right.
But otherwise,
and we didn't talk about this, but one of the other questions that came up was, is there a site other than the buttocks that can be used? But specifically, we haven't gone into this, but it matters where in the buttocks it's actually given, right? So it's got to be not in the gluteus maximus, but in the gluteus minor, right? That's a more of an upper outer portion. It was done in the clinical trials. That's an important thing to talk about.
it's not been tried in other places. So at the moment,
yeah, it's just too much. It's a lot of volume. And then one of the things that came up a couple times is the notion that if you look at the PK, those who had higher BMIs actually had more stability in the tail. Yet on the study, risk of failure, higher BMI was associated with failure. I bet that's a collinear thing with the Russian virus. I would bet.
That you're right. Yeah, I think that's the problem with that analysis in general. I didn't want to go into too much detail, but you have a large number of variables that they're looking at and very few failures, and a lot of these may be actually one another. So in the end, what is actually going to be the main
And then the final practical question: what about people that have buttock implants?
Oh, okay.
It's a problem, seriously, because it depends on where the location is, but you got to get it to the muscle and you don't want to go through the implant. So that could be a relative contraindication.
I suppose unless you could ultrasound or image, that the first time and have them marked, that's possible, but I don't know if there's a guidance for that.
All right, I'll let you continue on and then we'll wrap back to questions.
So this need for oral lead-in. So I think that it can be a challenge in the sense that, you have to make sure that it's all prescribed together and it's all arranged so that they get it, but I don't think it's a major potential impediment. Issues around drug supply, reordering, storage, preparation. I think this is much more complex than what we're usually used to doing, right? Writing a script and sending someone out with it, and the pharmacy will, if it's not in stock, they might start a few days later, and you don't actually know the date that they start until they come back to see you in 3 to 6 months. And whereas here, it's really, timing is everything. So it's going to be important to have a pharmacy that's used to using and supplying these medications so that they have them prepared, and that's the reason we've talked internally about for the oral medications, to give a script and have it filled so that at home they always have an oral backup in case of an unforeseen event. Who gives the injection and who's the backup for that person if that person is sick or away? This bridging stuff can get quite complicated. I think you have to be thoughtful about it. What happens when people just don't show up and you have to track them down, and it's the 7 days is coming up and you don't know who they are and your cell phone isn't working? Of course, cost and coverage. So this is where we're at right now in most of Canada, with it being approved by Health Canada, covered by many private payers, but most people aren't on the private insurance. And so we're waiting for provincial reimbursement, and there's these negotiations that get complex because it's more than just this cost of the drug, which has been priced so that it can be competitive with others. But there's this whole other added aspect of nursing, follow-up, administration, that sort of thing. And it's interesting to see how this is played out, and I can talk about that in some detail, how it's working here. I'm not sure how it's going to come out in the US, and maybe Mike, you've had some insights into that. But really, there's a big role for the company to be supporting this rollout because of the complexity compared to regular care. And I think we've talked about unforeseen situations quite a bit, but the obvious one is, the COVID pandemic. I think we're all hopeful that we're entering into a period of more stability with respect to COVID, but clearly it disrupted out of the blue regular clinical routine practice and follow-up. And that could happen, again, at any time if there's a big wave. And then what do you do to try to ensure that there's uninterrupted administration of these drugs? Okay, so with that in mind, I'm curious to know what proportion of patients that you follow do you think you will switch, or they will switch to injectables?
Have you been writing those letters to yourself? Dear Evan Hansen, this is going to be a good day, and here's why.
I started one.
Those letters are important, honey. They're going to help you build your confidence.
I guess.
All right. Okay. So that's interesting. So, yeah, I think, there's no right answer. We don't know where this is going to fall out. And I think about 10% is what people mostly say. Some people think up to 25%. So that's quite interesting. It's really hard to know. I think in part it's going to be capacity of our clinics and whatever outside clinic services are going to be available to us to do this. Probably this is what somewhere between 10 and 20% of the market, I think, is where we're going to see these fall out at least initially. And just I'll finalize with a few, slides and data slides that to support this thinking is there has been an anonymous survey that was done of about 450 health providers who'd been involved in aspects of the ATLAS-2M study and about how feasible they thought it would be to move from a trial situation where obviously things are all well set out to doing this daily in their clinic. And the majority of providers really felt that this was going to be feasible. This is monthly long-acting ART. But there were still, almost 40% who thought this could be problematic. So I think, that's where we're at. And the feasibility was greater if it were every 8 weeks as opposed to every 4 weeks. So I think the types of things that people were most concerned about, again, are these logistical things about traveling, how to get to the clinic, what if they miss a dose, whether if there's resistance that's hidden, if they have to move away. And interesting, this was an international survey, and North America and Africa found it much more feasible than other regions. So that might have to do with how we structure our health systems, but it also may have to do with acceptability too. I mean, I know that my personal experience is many of the people who come to me and said, when are these available? When can I get onto the injectable are actually from Africa originally. And I think it comes in some part because injectable treatments are much more available already in those settings. And so the experience with them has been positive, and it also, I think this internalized stigma issue is also another thing that's being addressed. And this is an implementation study, which was, again, healthcare staff and a variety of US clinics that were implementing long-acting. And I think if you look at what's in terms of barriers to implementation at baseline and a month later, the barriers, they drop, like the experience helped drop down the barriers in the sense that while they were seen, for example, the patient's ability to keep a monthly visit was really seen as a major impediment, that drops down over time. So I think in practice, we're going to see this play out in a way that is going to be feasible. But a large part of the feasibility, and I'll tell you that here, is that we have a high degree of support that's going to come with starting these medications through a patient support program, which I can describe it as I understand it, is that once a physician and the patient decide together to move in this direction onto these therapies, then you can sign up for a patient support program if you choose to, and they take over like all the logistical aspects. And what that is that from determining if there's insurance coverage, to finding a site that's closest to where the person lives, where the administration can take place, to scheduling the administration, to calling the people to remind them, to doing the administration, to communicating with the physician either by fax, email, or phone, in whichever manner they choose, and as much information as is wanted. If they've shown up for their appointment, if they've missed an appointment, what's happening. And in those people who've used the system so far here, it's been quite flawless. It's a small number of people so far, and obviously the first people we choose to enter into this may be, really great candidates. But that's a high level of support, and I don't know that that's going to be the ideal way to go forward forever, or the way it's going to happen and rolled out in the United States. So, what does the audience feel is the biggest challenge to implementing injectables for HIV therapy at this stage anyway? Ensuring injections are given on time, the need for this oral lead-in, remembering various scenarios that require bridging and how to do that, and the added clinical burden for administration or scheduling.
Dear Evan Hansen, we've been way too out of touch. Things have been crazy, and it sucks that we don't talk that much. But I should tell.
Yeah, so I think that's the concern about administration and scheduling is really a big one, but also that relates directly to this, ensuring that injections are given on time. If we think about this, actually, people are concerned about it, but at the same time, if there's a system in place, this will probably be the closest we follow people. If you go back to that adherence slide I showed at the beginning of the talk, we never know that people are that adherent to their treatment unless we're actively going in and looking at their pharmacy refills, whereas here, we're going to know, and you're going to know immediately when someone isn't. So it's actually having almost more oversight, more control, but we need that structure in place. Okay, so who in the end do you think might benefit most from these treatments? I think clearly those people who do not wish to take oral daily medications, and there's quite a few out there. And that's largely going to determine probably who's going to access these. But at the same time, there's going to have to be a frank conversation with the people who really want them. It's not actually, the role for these medications isn't like antipsychotics to ensure people get their schizophrenia under control, because people who need to be reliable, there's a different enjeu here, as we say in Quebec. Those people, if they can't ensure their injections are on time, then we risk these issues of virologic failure. And obviously people who don't take medications that could result in drug interactions, and those who don't have any underlying resistance mutations that the drug would be less actively. Great. So I've finished my material, Mike, and maybe should we do the post-test questions now, or should we go back in? I guess we have it up. So, and then maybe we can have a time.
Yeah, let's back up and address some of the issues, because we got about 10 minutes here, or 12 minutes for more Q&A. So I'm going to jump right in. One of the things that I think is potentially different about injectables, or ultimately implantables, that I'll talk about in a minute, is that suddenly, at least it feels to me, that I, as a provider, am taking more ownership of the adherence. So in other words, if I write a prescription and I hand it or mail it in, then it's up to the patient. I've done my job. I'm going to watch. I care about whether they take it, but doesn't feel like the onus is on me. If someone fails to return for a visit, and I realize we're outsourcing that potentially to some of these support folks, but in essence, I feel responsible if they don't show up, and that I have to take on the role of, oh goodness, they haven't shown up. What do I do? Or how can I bridge? And that's something I don't think about at all when I prescribe. What are your thoughts about that?
Yeah, I agree with you. And I think that the two thoughts I have about that is it does require some sort of robust system or structure to be able to monitor that, because you can't be the person checking in on them every day. It's some system, whether it's a nurse or a point person in your clinic, or outsourcing that to someone else, so that there's a way to get those reminders. But that said, I think if you have the conversations with the patients, and we're selecting patients that really are the best for these treatments, and you don't have to take on all of that responsibility by giving them, a prescription for the bridging. And then, if something happens and, people are able to manage and monitor, a lot of their lives, they can decide that, oh no, I'm going to have to take the bridging. And that takes away a little bit of the responsibility. But I agree with you. I think at first, we're going to probably narrowly recommend this to people we really think are going to be, very regular, reliable. But then, I think we have to not always be so paternalistic in terms of how.
Right. So let's dig into a little bit more about this slide and who might benefit. So Guy Vanderberg, but who, if he's French, would be Guy Vanderberg on Ward 86 in San Francisco General Hospital, is pretty excited about the notion of perhaps giving this option to homeless populations, as they have a lot of folks who are responsible. I mean, they want to take care of themselves. They just are in an unfortunate situation. What are your thoughts about that as a solution, that their meds won't get stolen and they'll come back in for their injection?
I actually think there's a lot of role for thinking very creatively about how we can address vulnerable populations using these medications. Again, it's more than just handing the medication over, in the prescription. It becomes needing to think about how do we have a system in place that we can make sure we can connect with those people. So if already you've got those systems in place with outreach nursing or outreach worker or peer support system, and then, I would think it would be a great way to pilot that as a project to see that you could do it. Because for sure, if you could do it every 2 months, and, that you can track that person down because they're always, frequenting the same area, that would be an option. But, it's going to have to be something that should be looked into, I think, going forward. Certainly, you'll speak about some of the other medications. It may be that even longer, the advent of really longer acting options or implantables might be something that might be even better for that. So.
Yep. Tim Cantor wants to know, how many patients have you and I had on injectables? And I think we've both been participants in studies, and this goes back, for me at least, 3.5 years, when I think they first started, and there's well over 3 or 4 dozen that have participated. I don't know what your experience is.
Involved in the very early latte trials, and so we had,
and like you said, the folks who are volunteering for this are very enthusiastic. I mean, this is something they've been craving, wanting for quite a while, and they jump on this early. Debbie Sestero wants to know about urban versus rural. Have studies looked at that dynamic?
Not to my knowledge. I think, again, this is an issue. For example, it's a lot easier in urban areas if we're going to use, for example, other sites that are already doing, injectable type therapies for biologics, that you can find a place that's quite close to them, and it could be quite anonymous. Whereas if you're in a rural setting, it could become an issue around disclosure, so in a small setting. So some of these things, I think, will need to be thought through. If there's only one place that you can go, and everyone else there is getting an injection for biologics, and you're being given the HIV treatment, it could be an issue. But yeah.
Yep. Several comments like this, but this one's from Dr. Earl, who works in a prison system and that the inmates really want this involvement. It seems like it's pretty ideal in that setting. The difference might be someone in jail versus prison where it might be more transient. What are your thoughts on that?
I think that's the difference that I would sort of focus on, is that we know that the turnover in our consideration, say, not the provincial prisons as opposed to the federal prisons, is quite often, and you can lose track of people as they're given their discharge. Whereas in people who are going to be remanded and stay in prison for many years, it seems like a potentially ideal solution, and also avoids some of that stigma too, because you come to nursing, you get it done, and it's good for 2 months, and you're easy to follow up. I think it would be
That's a great segue to Eric Leach Rodriguez's question, which I find quite interesting, because he's raising the point that that patients have been attending HIV clinics. They find that stigmatizing, and they prefer quarterly shipment of discrete supplies of ARVs, but coming in every 2 months to a location, he's concerned may out them. Yet, one of the things, just getting to one of the answers of the questions, is people might want this to avoid stigma. What are your thoughts on that?
I hear that. I think that, I guess the issue is really where you're going and how anonymous that setting is. And, clearly if you're going in a small town, as I mentioned, it could be different from in an urban setting. And if you're getting it, in say Montreal and one of these other centers, you're going to see the nurse, they're going to give you a treatment, you're going to go home, and no one's going to know why you're there, and no one's ever going to see you get a treatment for that.
Right. It'll be at a center where other biologics are likely to be given, so it's not really stigmatizing, hopefully. So a couple of questions that want to know a little bit more about these programs, and they haven't quite rolled out yet, but the concept you covered. Or any other thoughts? I guess the pharmaceutical company will give us probably more than we want to know in terms of information on how to access, but any other comments or thoughts on how that might work?
I guess the two comments are, one is that we're not sure that everyone will access them. I think there's going to be some people who will prefer to come. They're very connected with our clinic, and they prefer to come and get these treatments with our treatment room and our treatment nurses. But that quickly, if the demand goes up, that will outpace our resources to do that. And so we really are looking to these other programs. And from what I understand from the people who are using them quite successfully, is it's very seamless. You make a call, the phone call's done, they take over, and there's lots of communication, and you can select the degree of communication you want, to the highest level down to less if you're,
Yeah, and that communication between that center and us as providers is essential. We need to know what's going on. So Paul Ahrens writes an interesting question about whether if you're going to bridge orally, is it okay to use dolutegravir-rilpivirine fixed dose combination as opposed to the cabotegravir-rilpivirine? Probably okay. I mean, dolutegravir and cabotegravir are very similar. I don't think there's been studies of this, but it would be surprising to me if there was differential activity. Just a thought. I don't know of any data.
The bridging period, because you're going to lose the cabotegravir, level, and you might go back. If you're long bridging, you might have to reinduce basically with a higher dose at that first month again.
And there's a boatload of questions on payment logistics. If you're an FQHC in the United States, which is a federally qualified health center, if the patient's on Medicaid, and that's going to be something, I know that, as you said at the beginning, you've had approval for a year. I mean, yeah, there's COVID, but still not quite logistically available because the province hasn't worked out how to pay. That seems like it's going to be one of the bigger barriers for a lot of us.
And it could be quite complex because, especially in your setting, as I understand, there's so many different potential payers that it could be, they may have different rules about that.
I'm going to share my screen real quick because I want to review what else is in the future to kind of, if nothing else, just kind of balance out the program, because there is more coming along in the sense of not just long-acting injectables, but just long-acting drugs. And to think about that, here is a look at all the drugs that are in development, and several of these are going to be long acting, and this includes the broadly neutralizing antibodies and islatravir, which has a long acting half-life, as well as lenacapavir, which is a capsid inhibitor. And these types of things are going to be coming down the pike. This, I think, is a nice demonstration of that, where we have a listing here of all the potential ones, including broadly neutralizing antibodies. Ibalazumab, as you know, as everyone knows, is sort of a monoclonal antibody for failure, regimen failure, et cetera. And so you can see that this is going to be going even as long as every 6 months. But I think what's even more interesting is new ways of delivering this. This makes the point. This is a slide of using from Raj Gandhi, but how Merck and Gilead are starting to work together. It reminds me of the older days when Gilead and DuPont Merck worked together on a single tablet formulation for efavirenz. But these are some interesting ideas of how scaffolding could be created that could be implantable. And then another technology that is a patch with these little micro cones, if you will, and on that's impregnated drug. And the patch stays in place and can remain there for quite a while. These are some data showing out to at least a month that cabotegravir from the microneedle patch might actually, it's not going to necessarily be better or not than an injectable, but it's another way of getting long-acting medication. And finally, the notion of implantables, I think, are going to be not just in those tubes, but other sort of devices that we use all the time with long-acting estrogen preparation and that type of thing for birth control. We're going to find a whole new world emerging over the next 5 to 6 years. And so that's something else to be kind of excited about. We've got about 4 minutes left, and we're going to probably need to go to your post-test questions. So let's, before we go there, let's just kind of review for ourselves what you said. So obviously pregnant women, not a great candidate because of that. Someone who has poor adherence, ironically, you'd think this should help them, but if they're not showing up for their injections, right, they're not going to do so well. You mentioned people that might have drug-drug interactions like rifabutin. So I think that stigma might be something, commentary from one of the earlier questions aside, that could work. So let's go back to your pre-test questions if you want to share your screen again. I'll try to get some more Dear Evan Hansen music up here.
Okay, here we go. So back the pre-test question about the ideal patient. So we talked about this, I think. Vote.
So you found a place where the grass is greener, and you jump the fence to the other side. Is it good? Are they giving you a world like you never?
So there we go. So yes, it's obviously changed since the beginning of the talk, so that's good. I think we've covered this, but yes, I think this is the issue that we would all hope that we could find a treatment for someone who's really struggled with adherence. Some of the struggle with adherence has to do, for example, with just not wanting to take oral pills, but sometimes it represents a more important issue, and that's why we have to be sure that they can make it to their visits. So, okay. And then the second question, which was about which statement is true.
I don't need you to sell me on reasons to want you. I don't need you to search for the proof that I should.
I'm going to have a disclosure on what Broadway musicals I like.
Yeah,
as opposed to for conflict. I was just obsessed with this today because they announced that the trailer got released for this movie for Dear Evan Hansen. So there you go. So it looks like a lot of people got this one right.
right. Yeah, I think there's only a few people who missed a few slides of mine. Okay, I'm gonna get out of here. No more
Yeah.
slides.
So we've got just about a minute left, and there were, I don't know, 64 questions we still didn't get to. So we'll have to have some follow up on this. But I think this was a wonderful review of a very complicated in its way, but new and emerging approach for treatment that we really haven't engaged before. So I think you've done a great job of putting that out there for us. Jose, I might need the final slides just to remind everybody of how to get their CME credit. So evaluations on how to claim this is on the website, and you'll be able to go back there. This is the same way that you registered. And so you go back to the IAS-USA website, IAS-USA.org, and it will walk you through this. You'll be emailed an evaluation form tomorrow. Please fill that out. That really helps us plan. I can tell by the fact we have 64 unanswered questions that there's a lot of desire for more information about these new approaches to therapy. Next, yeah. So there's some upcoming webinars that we'll be doing on hepatitis B prevention management, civil society solutions to COVID, stuff on COVID vaccines and how variants come in, prevention of anal cancers, and the role of the microbiome. Lots of wide variety of things that I think you'll find of benefit. They're typically on Tuesdays, like today is at the noon hour Central, 1 o'clock Eastern, 10 o'clock Pacific. The update, there's a concept of HIV prevention and treatment and care in the COVID world that's coming up in just a couple days on Thursday. And you can see the topics listed here. I think there's still room in this one if you want to register. And if they fill up, there'll be a waiting list, but I think you can still get into that. And again, this is more of our usual half to 3/4 day activity. So it will require to take a little bit of time off work, but I think the topics, as you see here, are quite varied and I think very germane to how we're practicing every day, especially for the STIs COVID. And then we have dialogues. The next one coming up is about public health, scientific, and clinical aspects of the pandemic. There's an expert discussion between George Rutherford and Paul Volberding, which is, I think, the third time they've met. So it'd be interesting to hear how that conversation's evolved. Early treatment with Kara Chu and Judy Currier, and then COVID meets HIV and how that comes together again. And these have been archived and are available to you to listen at your leisure by going to the IAS-USA website. All right. So thank you, Dr. Klein. It's been great to be with you. And I also want to thank the audience for hanging in there with us. We had almost 500 people, I think, online at any one time. And I think thanks again to the IAS-USA staff for doing such a great job in putting this together. Thanks, everybody. We'll see you next time. And thanks again, Dr. Klein.
Much, Dr. Saag. It's a pleasure to work with you and your music.
Bye.